very quickly. Could she, when she opened her eye, did she know who she was? Yeah. Did she know where she was? Yeah. Did she know everyone around? I have a patient who, when he goes into tonic-clonic seizure, and he comes out of it, he thinks he's in the middle of Iraq in combat. So there can be quite a bit of confusion status. He comes out of it quite stressed.
How long does the postnatal state for the tonic-clonic seizures generally last?
I would say they're not, and then there's stages of it. At first, when they have no idea. Some of them don't know who they are. Most of them quickly. That's the first thing that comes back to is who you are. Then quickly they start oriented within 20, 30 minutes of where they're at, who everybody is, and what happened to them. But then they're not going to feel well too. You've got a lot of muscle contraction. You hit your arm, maybe dislocated your shoulder. So I throw that into a postnatal state. So they've got myalgias from head to toe. Some of them have headaches too. Get bad migraine that day. So you want these patients controlled. You know, if they have these frequently, then their employment suffers. And we'll talk about driving restrictions and things like that if they have seizures. So some of them may take a couple of days or so before they feel back to their normal self. It's like a post-flu, you had the flu and then you just don't quite feel right. You just go blah. And then we will go away for a few days afterwards. So migraine, that is a big one and can be tough to diagnose. Everyone seems to think that with migraine you have to have the worst headache ever right after whatever the aura was, or it's not migraine. Well, they may have a different pain tolerance than some other patient, or they may have a mild headache, or they may not have a headache, they may just have aura. You may have a patient with ocular migraines who sees flashes of light, sees a zigzag of crescent, their vision gets affected, they can't see very well in the middle of it, and it's usually positive symptoms. They're seeing something that's not there, crescent, flashes of light, or they're not going to have a black spot and their vision looks black type of thing. Although there's a very rare type of migraine, and I happened to see one where this lady's face would go numb and weak. So I've seen the true weakness, and then 20 minutes after that, the migraine comes on. So migraine aura is a very fascinating thing because it could be mask just about anything. A focal seizure, they may have a sensory traveling up their arm. With the stroke, they went numb, their arm, their face, boom, it went numb. With the seizure, you may have some that travels up, and with migraines, you may have 1 to 2 minutes of, they feel slowly, I start feeling in my hand, and then slowly came up, and then I felt it in my face. It's unlikely they're having a stroke. And then, 20, 30 minutes later, I got a migraine. It's a migraine aura. This is not a seizure problem. TIAs. I feel like that seems to be a simple diagnosis for some, to just stick everything into a TIA. Well, you had a TIA. And then patient, to me, I worked in cardiology for 2 years. If a patient has had several TIAs, they seem to think that it's not a big deal. Oh, I just had a TIA. Oh yeah, my face went numb. That was another TIA. Your patient is only going to have so many TIAs before they have a major stroke. You can't have a patient whose face goes numb for 10 years, in the same spot, the same way, every few months, and it's multiple TIAs. This is one that you're going to worry about. Are you stroking a stroke tomorrow? Or this is probably not a TIA. They can have this is more of a rapid onset of the sensory loss, and they're going to have a negative symptoms. They're going to have a loss of vision, a black spot in their vision, or they lose vision in the periphery or altogether. In one eye, they're going to have weakness. They're not going to feel. It's not a tingling. They're going to have numbness, and that lasts less than 60 minutes. And then parasomnia and cataplexy, I'm not going to go into this much. Because I don't see this much, but it essentially goes into sleep disorders. I'm sure you guys know about those. So EEG, this is something that in your ICU or hospital patient, The patient's hooked up to the monitor that's right there, but you can perform these on outpatient basis. A patient would need to be sleep deprived. Sleep deprivation tends to lower their seizure threshold, and you want that brain to be a little irritated. You can have some abnormal electrical activity on the EEG suggestive of a seizure disorder when they're not necessarily having a seizure at that very moment. So if they have a seizure while you're having EEG on them, that's great, but that's most likely not going to happen on a scheduled appointment on Friday afternoon when the patient comes in sleep deprived. But there's going to be some excitability, some spikes that you're going to see in the brain that's going to clue you in. This brain is a little bit more irritable, and this type of pattern we see where she's at risk. She can go into a seizure, and she may feel fine. She's talking to you, walking around. So not every normal EEG means that they don't have a seizure disorder. So, but if they do have an abnormal EEG with those spike and sharp wave activities that is concerning for a seizure problem, then it will help you in managing a patient, starting them on the anti-epileptic drugs, stopping them. We'll talk about that a little later. And also, if you have a normal EEG, you may consider not starting them on seizure medications after their first seizure. But if it's abnormal, that means they may have another one and another one and another one. So we need to calm that electrical activity down with meds. So they have these leads that are hooked up all over their head. They lay in the comfy recliner, the lights, and then there all sorts of things are done. The technician is going to tell them, open, close your eyes. They're going to tell them to hyperventilate. They're going to tell them if they have heart failure or severe COPD, we may skip hyperventilation. They may give them a photo stimulation where they see some flashes, and we're trying to get patient's brain to lower their seizure threshold, see if we can see something abnormal on the EEG. And you may need to repeat those again. Video-assisted EEG is the same, similar, but it's very helpful. You can do that within, I think, up to 2 days. These patients are wearing leads on their head at all times. They're just not washing their hair. They can sponge bathe otherwise. And they have cameras set up in the major rooms of the house. So it's very helpful for that patient that has every type of seizure in the book, so you haven't quite caught it, you can't figure out is this a seizure, or this patient was started on seizure medications, they've increased their doses, you added another medication, and they still having breakthrough seizures. They swear they take them, family members swear they take them, and they think, okay, maybe these are not seizures. You get them into with a video-assisted EEG company. They get them hooked up. This patient walked through the living room, fell down, shook, but the EEG is normal. So this is not a seizure problem. And we hope to catch those so we can make the diagnosis. I got ahead of myself again. I have to catch up, figure out where I was. So there are some things that can cause some subtle abnormalities on the EEG that does not necessarily mean that they have lower seizure threshold. So some patients that are blind may have some occipital spikes, so they're not going to have a perfectly normal EEG, but they may have some spikes. And this is, again, you're not going to be reading this, but I see my dog read quite a few of these, and I'll hear, Luba, come here. I go over across the clinic. Okay, tell me about this patient. What are they on again? How did he present? So it's not necessarily, it's not always black or white. Sometimes history is important, what medications they're on. If they're on benzodiazepine, if they're on bupropion, if they're on tramadol, they may have some epileptiform discharges there because of the medication that they're on. They may have, now this one I've never seen, but I thought it was really cool, so I put that in there. generalized spikes in relatives of patients with genetic epilepsy. I doubt this will ever be on the test, but I thought, hey, your family member made you have a abnormal EEG. Bupropion and tramadol, and there's two more we'll list later on. These are actually, benzodiazepines as well. I've seen that quite a bit, may cause some little epileptiform disturbance. Even though we use benzodiazepines, I don't have a separate slide on this, but it is important. Even though we use Valium and Ativan to treat status epilepticus, this is not even an oral form tablet that you're going to be prescribing to your patients on outpatient basis. This is to stop status. If it's a patient that just want the Ativan to get their seizures under control, this is not going to work. Number one, they need to be on extended release, that they have a continuous dose in their bloodstream. Number two, it's heavily habit forming and addicting. And number three, if they forget that pill, if the patient forgets your seizure medicine, then yeah, they're at risk for breakthrough seizure because they forgot their medication. But their brain may be happy, and I may have a patient that takes their Keppra once a day for a long time before they have that seizure. But when you have a withdrawal from benzodiazepine, when the shorter acting benzodiazepine is the type of benzodiazepine, the faster your curve drops as this medicine comes out of your system, and this is when your patient is at risk. So it lowers your seizure threshold during that time. So let's say you have a patient with anxiety, high anxiety, and their psychiatrist is prescribing them PRN Valium, and they have seizure disorder. And you put them on seizure medicines, but you have to have that heart talk with the patient. I know it's the only thing that works for your anxiety, but this puts you at a risk for seizures. You gotta need to be, if you cannot come off of it, you need to be on a long-acting, something like Klonopin, you need to be on long-acting benzodiazepine. The short-acting benzo is not going to do any good. It puts you at risk for seizure. And I think from 6 years of seeing seizure patient, I have only one patient who is on Klonopin as part of their seizure management, and it's her third agent, so she's already on 2 other seizure medications, well controlled. She came into me on it. She takes a super low dose twice a day, very compliant, been on it for years, always comes into her appointments and kind of all the patients I have. She's the only one that I have that's a So. So your patient comes in with a seizure, and if they had one seizure, that does not necessarily mean that they're going to have a lifelong epilepsy diagnosis. They may have more than one in 24-hour period, and again, in 24-hour period, it does not mean necessarily equal to a long life diagnosis of epilepsy. Anti-epileptic medications. Although I would argue a little bit on this. If I have a patient that had 2 bad tonic-clonic seizures within 23 hours apart, I may get a little worried. But some of these focal seizures, if they had several within 24 focal seizures, you're actually going to be on meds. So you can have either. So we'll talk about management of the first seizure. So this is a patient that had one seizure. They came to emergency room. They came into maybe even on the prescription of Keppra, and you're trying to figure out, do they need to continue taking this Keppra? Am I going to stop it and then put them on something else? So first of all, we're going to try to figure out, was this a provoked seizure or was this an unprovoked seizure? So with provoked seizures, I had a young lady, and the reason I like this story is because it kind of includes all of them in there. as far as what can you do to lower your seizure threshold. She may have never had a seizure, may have never even known it was her one and only. I've seen her several years ago, haven't seen her back. I don't think she had any more seizures. But this young lady wanted to go to a concert. She just turned 21, so she wanted to go to a concert. She drove for a long period of time, got maybe 3 hours of sleep, then went to a concert. She was in the front line, loud music, flashes of lights, and then she had quite a few beers, and that night she had a seizure. So we talked about sleep deprivation, flashes of light, bright lights, and lots of alcohol. No, just drinking some, having a beverage here and there is not going to significantly lower your threshold level. But if you're a chronic alcoholic and you stop drinking, or if you go on a huge binge drinking thing over the weekend, and you drink quite a bit, and I've heard some people can drink quite a bit, and then you go not sleeping, then you may have a seizure. So do you, or they may have had a substance abuse problem of some sort. They may have used cocaine, amphetamine. You know, I get marijuana question a lot. There is no legitimate studies out there for the FDA to approve marijuana as a sole treatment of seizure disorder. But if they're doing synthetic marijuana can actually fry their brain and give them a seizure disorder. So sometimes they'll ask me about marijuana. I'll say, have you ever used marijuana? Have you ever smoked pot? They may say yes. I said, was it synthetic? And so I have a patient that developed a seizure disorder from smoking synthetic, and he's actually continued. He had to be on meds for that. Now, certain medications, tramadol. If you have a patient who have known seizures and they got a really bad back pain, and you are so proud of yourself because you didn't give them hydrocodone, you gave them tramadol. It is now scheduled drug too. It is somewhat habit forming, not like oxycodone and hydrocodone, but it got on the list as of the past couple of years or so. But again, you're proud of yourself. You gave them tramadol instead of that Loratab that they asked for, and you gave them a high dose, and it's a seizure patient, and they had a seizure that weekend. Don't prescribe tramadol to seizure patients. I think they'll probably be okay with the lower dose here and there, but, you know, telling a patient who's in pain to use a lower dose of this, you can't control that. They're gonna hurt, they're gonna take more of it. And same thing with bupropion. Don't prescribe it for depression in a seizure patient. And these two I don't see very much. The Theophylline's just not prescribed very much. Old time is a biggie drug. So. And in general, your provoked seizure that was probably caused by something and pushed this patient into a seizure, is going to be a generalized convulsive type of spell. This is not going to be, I went for, I suddenly decided to quit drinking after 20 years and now I have a little twitch in my arm. That's not, they're going to have a seizure that's provoked. They're going to lose consciousness, they can shake, and have a post-mental state afterwards. But it's important to take a good history. Is the patient a diabetic? Is the patient an alcoholic? Does this patient have heart problems? Or were they severely hypertensive? So these patients with just one isolated provoked seizure, most of them are going to have a normal EEG. Occasionally I have someone that comes back with pretty impressive abnormal EEG. What's impressive, what's not, your neurologist will tell you. Say, this is impressive, start them on that. So then you say, okay, they're at risk for another seizure, and if my EEG is abnormal, technically I would start them on seizure medication. And if they have not had a seizure, they were stable in their meds, they were compliant, after 2 years of being on their meds, we can do another EEG, and if it's normal, then we can stop their Keppra or whatever anti-epileptic medication that they're taking. But if their EEG is normal, and you took a really good history, and, you know, this patient of mine, I guarantee you she's never, from then on, slept only 3 hours, went to a concert, had quite a few beers and stood in the front of that line. So she's fine. She did not need medications. So you can confidently make that decision. If they had a provoked seizure, let's say your patient is an alcoholic, and alcoholics can always drink again, and then they had a provoked seizure, and then they had another provoked seizure, and they had another provoked seizure, then if it's more than one, you're going to start them on anti-epileptic drugs, and they're going to keep doing whatever they're doing, or you're at risk. So who would most likely end up taking anti-epileptics? So this is your diagnosed patient with seizure disorders. They've had multiple seizures throughout their lifetime. Don't stop their meds, even if it's been 10 years since their last seizure. You know, if you did that one trial after 2 years, they had that one seizure or two, they were on meds for 2 years, EEG was normal, you stopped their medication, and within a few months of that, they had another seizure. Don't try that again. That's it. They're going to need to be on meds. And so this is a diagnosis of epilepsy now. If your patient is over 60 years old, and they started having seizures later in life, then you can have a safe bet that it's probably a ischemic event of some sort that's sent them into a seizure. And then these patients' MRIs can be really tricky because they have, you know, this is an overweight, diabetic, high blood pressure, high cholesterol patient who's got a little bit of carotid artery stenosis. They had a couple stents placed in their heart. So, you know, pipes are clogged up everywhere. So you get an MRI and it comes back with this patchy, white, non-specific changes all over. They may have had a little tiny stroke here and there, and now it just looks like someone just dumped a bunch of snow on their brain. A lot of microvascular disease, tiny, tiny arteries in the brains are closing off. So this patient would need to be on anti-epileptic drugs. They're probably a mini stroke, mild little stroke hiding here and there. They may have had a stroke that they didn't even know. It's not uncommon for MRI to come back with some scar tissue from a previous stroke. They had no idea when it happened. It was old, they had no idea they had it. So they're at risk for another. If there's a structural abnormality on the MRI, this is where that activity is going to start, around that scar, around that tumor, around that resection area where their meningioma was resected. So there's something that disrupted the brain tissue, and now that's where seizures are going to like to start. Insult, and we've talked about a patient falling from the roof, and they hit their head really hard. They may have a brain bleed, they may not. But with one single trauma event and post-traumatic seizures, you can get another MRI, and if they had a post-concussive type of seizure, and they were stable and good for 2 years, they didn't have a brain bleed, they didn't fracture their skull, you may try to get them off their meds, and they may do just fine. They may just have one due to trauma. But if they had an actual insult, a hemorrhage, then they would need to be an anti-epileptic. EEG is important here. Now we'll talk about significant brain abnormality, mass, tumor, resection, brain surgery. Nocturnal seizures tend to recur, and nocturnal seizures can be tricky to diagnose. EEG is helpful. You can do a video-assisted EEG, or you can do an overnight EEG, where if they're just having their symptoms at night. And so this patient may not make convulse. They were asleep, they woke up, they may just not quite feel right, they may feel tired, may feel just not right. Some bite their tongue, they may see some blood on the pillow. Oh, I had a seizure overnight. And unless they have some enough convulsing that they're really hurting the next day, or they have a family member that said, oh, you convulsed last night, or I saw you shook, they may not know. So these are tough to monitor, and these would be tough to know, are they having these, or are they not having these? So you'll do an overnight EEG, you'll diagnose that these are more of a nocturnal seizures, and you can start them on medications. And then focal seizures, or focal seizures with secondary generalization. Again, these are most likely going to need to be on anti-epileptic drugs. I've included juvenile myoclonic epilepsy here. I have yet to see it, but it's important because this tells you, this is actually the most common genetic epilepsy, about 5 to 10%. And so this patient may present with generalized tonic-clonic seizure, and it may be provoked. It may be a young patient that, used a drug of some sort, or went binge drinking and didn't sleep, or maybe studied in college, didn't sleep for 2 weeks straight, or whatever the cause is. And you go, aha, so this was a provoked seizure, one event, the patient is healthy, brain scan is healthy, EEG is normal, all their blood work is normal, so we don't need medications. But they may have juvenile myoclonic epilepsy, and so they may have some infrequent absent seizures, or they may have some little myoclonic jerking in the mornings, especially if they're sleep deprived, that was seizures. So if they had several of these before that just went undiagnosed, and they had a major tonic-clonic seizure, and that's how they presented, and you miss these, you may not end up giving a seizure medication to a patient that actually needs to be on that. So take a very thorough history as far as anything funny that they've had before, any symptoms that they've had prior to this that will be of concern. Valproic acid is most effective in these types of seizures, but there's some side effects. We'll talk about that later. Lamotrigine is a second drug of choice that works for this type of epilepsy. And in these patients, that they actually would need to avoid the common provoking factors, sleep deprivation, alcohol, and so forth. That puts them at risk for seizure. I'll go over medications. I know you guys probably had or will have a lecture on meds, but I like to go over some clinical aspect of it too, of what I typically see the most in clinic as far as side effects and tolerance and issues and what we monitor for. So we'll start with valproic acid. It's available in extended release, otherwise twice a day. And side effects, you're going to see similar side effects across the board for all anti-epileptic medications. So the way I explain it to patients is that this is something that's going to slow down the overactivity in the brain. And anything that kind of slows down your brain can make you feel like you're a little slow. So they may be not as sharp in thinking sometimes. They may be sluggish. They may be fatigued. And patients don't like that. Then this is some meds are a little bit better than others. The older doesn't make them as tired and sluggish, but some of the older ones, especially at higher doses, do. And so you may have to really encourage your patient. I want another one. This one makes me a little tired. This one makes me sleepy. And sometimes we have that discussion. Okay, if you have an untreated seizures, you can die, or you can deal with a little bit of fatigue from this medicine because I don't have anything else. All of them across the board are going to probably give you some type of fatigue. And as you practice medicine, you're going to hate seeing fatigue on your chief complaint. You're going to hate it. So you're looking at, in rare cases, it actually can cause encephalopathy, high ammonia level, hepatotoxicity, pancreatitis, and this is one of those drugs that is the highest rate of tetragenicity. Don't use this medication in fertile females. So if your patient has ovaries and uterus, they can get pregnant. I don't care what their sexual orientation is. I don't care how old they are. If they've got ovaries and uterus, you need to think about this. It doesn't matter what. Because if you, this is gonna also need to go in your chart for all seizure medications across the board. Some are a little lower, some so I say about 5%. 5% risk of tetragenicity with seizure medications. Some are a little bit less. This is about average. So even some of those safer seizure medications that we'll talk about, like Keppra and lamotrigine, that's a little bit more pregnancy friendly. There's still risk, lower risk, but you're going to need to document that you've discussed this with your patient. You ask them what is their form of birth control, and you documented that, and that's very important. This patient gets pregnant, there's spina bifida, cleft palate, and this is going to come back to you. You're the one that prescribed that drug, and you're the one that didn't. You may talk to her about it, but you didn't document it. So I document this on every single patient that has uterus and ovaries, and at every single visit. Discuss risk of tetragenicity, discuss risk of tetragenicity. Sometimes I go as far as saying this patient is not of a childbearing age, or I can say this patient had hysterectomy, or I say, this patient claims her husband had a vasectomy. You got to document it. And any patient that is going to be a pregnant patient on seizure meds is going to automatically be a high risk, they're going to be with a high risk OB. So they're going to go to a specialist. If you practice in Oklahoma, that's most likely going to be an OU. They're going to monitor them closely, more blood work, more ultrasounds. Some patients, we can stop their seizure meds, that it's approaching those 2 years. She really wants to get pregnant. It's been 2 years. We check EEG. Okay, we can do a trial off medications. Ideally, it'd be nice if she could get pregnant, carry through pregnancy, and not have a seizure, and not be on any of these meds at all. That's perfect. But some patients, we can't stop their seizure medication, so we may have to change to a different one. I have them take high doses of folic acid for several months before they're trying to conceive, and we make some plans. We get their information about high risk OB. The minute you get pregnant, this is who you call, this is where you need to go. And the best pregnancy, if you have to have a pregnancy with seizure medications on board, the best pregnancy is pre-planned pregnancy. So you don't want surprises, but they're still going to happen. And this medication is actually approved for migraine prevention as well. Again, probably not in the young, fertile, and female. Dilantin, we've talked about IV Dilantin before. So you will not start this in a brand new seizure patient. There's better drugs out there. One thing I don't like about Dilantin, in addition to all of this, is there's always a risk of Dilantin toxicity. This patient was on Dilantin for many years, doing great, and then they come into you and I don't feel right, I feel like I'm about to get a flu, I feel achy all over, I feel dizzy, things are spinning, I got a little tremor. It's just, I don't know what's wrong, but something is wrong. You get their Dilantin level and it's really, really high. And the way that your body metabolizes Dilantin and the way that so it's not linear. You can decrease Dilantin level by very little and their levels are just going to plummet down. Or you can decrease it by very little and their trope levels of Dilantin, they're not changing. You decreased it a little bit and it's almost the same. You decreased it a little bit, it's about the same. And you want to go, okay, maybe I'll increase it by 100 instead of 50. You're really tempted because this patient's not feeling good when their levels are this high. and then you decrease it by a little bit more, boom, now they're subtherapeutic. Now they may have a seizure. So I usually, as I decrease their Dilantin level, whatever else they're on, most of them are not just on Dilantin. Usually if they're on Dilantin, they're on 2 or 3 other seizure meds. If I am able to, I'll increase their Keppra or increase one of their other anti-epileptic as I'm decreasing Dilantin, because that drop is gonna happen at some point. And you're gonna need a Trove Dilantin, which is, you're gonna check it about 8 hours after they took their medication. So I check it first thing in the morning before they take their morning dose, or late at night later in the evening before they take their evening dose. Long-term use is also something. Some of my patients are on Dilantin. It is dirt cheap. So some of them don't have insurance, and they stay on this for years. And if they choose to stay on this for years, even though there's better meds out there, then I am also going to document. I need to document at every visit, but sometimes I may skip one dictation, that we've discussed risks of long-term use. Sometimes I make their own couple of these: decreased bone density, gingival hyperplasia. They need to know that the longer they're on Dilantin, the more they're at risk for cerebral atrophy. It can cause peripheral neuropathy if they've been on it for years and decades. Decreased bone density, anemia. But the gingival hyperplasia and decreased bone density are a couple of the big ones. And then elderly, they may have a lower dose, and it's just really hard to find that right dose for some of these. They can be stable for years, and then all of a sudden your levels are all over the place, and you're scrambling because you don't want them to have a seizure, but you want them to have normal Dilantin levels and not be toxic. Tegretol, we don't use these for myoclonic epilepsy, but they're excellent for focal seizures and generalized tonic-clonic seizures. Oops. Where did that go? Thank you. I use that for trigeminal neuralgia quite a bit. It's a good drug for that neuropathic sharp pain. If I was to use it for something other than seizures, headaches, nausea, fatigue, they may get hyponatremia, weight gain. Same thing with the trileptal. Both of them can cause a small reduction in sodium. So if you get a blood work on this patient and their sodium is borderline low, there's nothing to be worried about. Occasionally in elderly patients, when the drops lower than borderline, you may need to stop it or change it to something else. But they kind of run just borderline low, borderline low, borderline low. And you may even check blood work and go, keep coming back and you go, why is their sodium levels always just right there, just on the verge, always a little low? Why is their sodium level low? You look at their medications and, oh, they're on Tegretol. That makes sense. Then you just leave it. To be honest, I have never tested for this, but I put it in here because it is black box warning. These patients' risk of Stevens-Johnson syndrome is very rare, but there's actually subpopulation in Asian countries that their risk is 10 times higher. And so they would need to be checked, a genetic blood test for this gene right here before you use it. I think it's one of those maybe more of something that's cool to know for the test. I haven't checked that, and if I'm really worried, I may just use something else if I have to. Trileptal, it's kind of a sister medicine of Tegretol. So slightly different, but yet similar. First line for focal seizures. This one we actually don't use in monotherapy for generalized epilepsy. Twice a day dosing unless it's extended release. And then you can also easily convert from one to the other. You can even do it overnight. Now, that's if their carbamazepine dose is 800 milligrams or less. So you can simply say that 300 milligrams of oxcarbazepine for every 200 milligrams of carbamazepine, and you can just make a switch overnight and into, this dose this night and then the other dose next day, and everything's great. If the dose of carbamazepine is higher than 800 milligrams, then you may need the help of your local pharmacist or your supervising physician on what dose to use. And one of the reasons I've included that in here is because this is not typically something you would do with seizure medications. You don't go, okay, you're on Keppra, okay, so tomorrow you're going to be on Vimpat. So here's your prescription for Vimpat. Start taking it. Stop your Keppra today. Start taking your Vimpat tomorrow. You don't do this with seizure medication. You're going to slowly taper one down as you up taper the other, and usually within the week, on that last day when you've reached the maximum dose of your new drug that you want to use, that's the first day that they don't take any of the dose of the drug that they were on before. So you kind of slowly transition. You want to, every time you switch their seizure medication, you put them at risk for breakthrough seizure and even status. So this is something you will be doing if you work with a neurologist. You're going to slowly down titrate, and it's a big old list, and it is something that you're going to need to write out for a patient, make a copy of it, and scan it or put it in the chart somewhere to where anyone that looks at that paperwork, they knew that you explained everything. So you go week 1, this many milligrams of this medicine, this many milligrams of this. Week 2, this many milligrams of this medicine, and you talk to them ad nauseum. You've got 20 patients waiting, but you're going to spend 30 minutes explaining to this patient how to transition from one to the other. And I don't do it over the phone. If someone wants to come off their seizure medications and, I want to try something different, I don't like it, side effects, this and that, you come in, that way we can talk, I can explain it, I can draw it out, I can write it out, and then I can make a copy of the sheet that I gave it to you, I signed it, you signed it, that we know that we were all in the clear on how to do it, because it can get pretty complicated for some patients to do this. They're doing it themselves at home. They take by 50 or by 100 less every week as they increase this way. Same side effects, drowsiness, fatigue, and actually the newer medications are fairly well tolerated. I will go over the most common side effects that I see that main patients may complain about. This one, another one with the hyponatremia, I've already mentioned that. Topamax, it's one of my favorite drugs. You either love it or you hate it. I use it a lot for migraine prophylaxis. I don't go over 100 milligrams though on Topamax. Topamax, me and a friend of mine calls it Stupamax, because it can really slow down their cognition and thinking and give them trouble concentrating. Once they go past 100, that goes up and up and up. So some elderly patients that's been on higher dose of Topamax for a long time may start worrying about dementia and like I'm forgetting things. So a lot of times I'll stop it and that'll return to normal. Some been so well controlled on Topamax for so many years they don't want to stop it. It's like, you're gonna may have some trouble concentrating. I've had college students who have seizures or even some headaches patients. Headache patients, you can stop it. Of course, with seizures, you can't just abruptly stop it. But they have hard time around finals and things like that, and hard time concentrating. So you will see that complaint quite a bit. You titrate Topamax slowly because most of the side effect dose dependent. So if their body can adjust to that lower dose as they go up and up and up, then they may actually do better. If I give anyone 200 milligrams twice a day, they're not going to take it. They're not going to feel good on it. But if I slowly titrate it over a 2-3 week